secondary to hypoglycemia, you can do that within a frame of like 7 days. Emily Tam, one of the neonatologists here in our group, published paper showing that the diffusion restriction on the diffusion weight images of patients with hypoglycemia can disappear after 1 week of the event. So if you do the images later on, you might not see the evidence of acute injury and energy failure. I mean, you might get some changes in T1 and T2 signals later on, but the acute diffusion restriction, classic occipital injury usually happen within the first 1 week of the instance of hypoglycemia itself.
Okay, if there is any questions, any other questions? Okay, thank you, Professor Sameh. And we move to the next speaker.
Okay, it's my pleasure now to introduce Dr. Amr Elshahd. He has been graduated from Mansoura University as his master degree in pediatrics and his PhD as well. During this time, he has completed his fellowship, medical fellowship in sick children, hospital of sick children, and he has also diploma of medical education. Amr has worked in Egypt for quite some time. He was a co-director of Egyptian Neonatal Network. Now he has another fellowship in transport and neonatal, and the third one, neonatal neurology. He is now his assistant professor at the University of Children, Toronto, and he is the co-director of the neonatal neurocritical care unit neurology of preterm infant and the neonate with hypoxic ischemic encephalopathy. Dr. Amr works on enhancing brain monitoring in newborn at risk for brain injury and optimizing developmental assessment and support in the neonatal neurodevelopment follow-up clinic. His research is focused on studying hemodynamics and the cerebral oxygenation in neonate with HIE, pattern of brain injury, and the evaluation of different prognostic utilities in HIE. Now, Dr. Amr will talk about the neonatal seizures. The mic is yours.
Okay, great. Thanks, Dr. Rida. It's very nice to meet you all. And Dr. Rida has been my mentor for years and still my mentor. So thanks so much. And I learned a lot from Dr. Rida and Dr. Safa, Dr. Afaf. So thanks for giving me the opportunity to present today about neonatal seizures. I know it's late now in Cairo. Can you see my screen?
Yes.
Yes, there.
Yes, we can.
All right, perfect. So I have nothing to disclose, and this is where I work now in the Hospital for Sick Children in downtown Toronto, and this is our busy neurocritical care units. The objectives of my talk today is going to be really, I'm trying to cover the following objectives. I will be trying to cover the vulnerability of the newborn brain on seizures. I will go through the different immunology of seizures and the movements that can mimic seizures. And I hope that the internet will help me in that. And I will try to talk about the reliability of different tools in diagnosis of seizures accurately. And finally, and briefly, we'll touch base on the treatment options that we have currently for management of seizures. Is a neonatal brain predisposed to seizures or not? And the answer is definitely yes, because newborns are at much higher risk for seizures more than any other period of life, due to their higher risk for exposure to external factors such as birth trauma, hypoxic ischemic encephalopathy, and infection, as we all know. But more important than this, they are actually having intrinsic factors in their brain that put the brain into a status of enhanced excitability. I like this schematic approach or the schematic diagram here, because you can see here that the developmental profile of the glutamate and the GABA receptor expression in the rats and the equivalent age of the human brain. And as you can see here, the excitatory neurotransmitters and the excitatory receptors such as the NMDA and AMPA and even the kainate receptors are peaking during the neonatal period. while the known GABA inhibitory receptors and neurotransmitters are just starting here at the neonatal period, and then they peak later on. But more interestingly here, as you can appreciate, paradoxically, the GABA can have excitatory action in newborn, and especially in the preterm brain. And I will touch base on that in the next slide. So why the GABA would have paradoxical excitatory action in newborn brain? This is most likely related to the fact that the preterm brain and early newborn brain is lacking what we call the potassium chloride cotransporter receptor, which is responsible for the efflux of the chloride outside the cells. So what's taking the upper hand now is the sodium potassium chloride cotransporter that brings a lot of chloride into the cells. So once you have GABA stimulation for any reason, this will result in efflux of the chloride outside the cell and influx of the calcium inside the cell, which will result in depolarization or excitation. That's, you wouldn't expect that normally to happen in full-term neonate and more mature brain, because now you're going to have the potassium chloride channels and the sodium potassium channels will be less active. And the result will be, on the other hand, influx of the chloride into the cells when you have GABA stimulation, and that will result into the normal inhibitory repolarization action of the GABA. If you don't mind, I'm just gonna switch here because I think this is like a different version. This is gonna be a very long version of the presentation. So if you don't mind, I'm gonna stop sharing and then open the other short version of this presentation, if you don't mind. I'm sorry about that. Okay, so I hope that you can see the screen again.
Yes, we do. Yeah. Okay.
All right, so let's continue now. So now we're gonna talk about the different immunology of seizures, and I'm gonna review with you examples of the rhythmic motor activities that they can mimic seizures. So here in this example, this is an infant with jittery movements, as you can appreciate here. They are not seizures. They are typically very rapid movements and very short in duration and most likely distal rather than being proximal. They are typically not isolated to one arm or one limb. They usually present in different limbs. And they are not usually associated, as you know, with any changes in the vital signs. And if you put the baby on electrographic recording, you will not find any changes in the electrical activity. The hallmark, of course, as you can see here in this infant, is that when the nurse put her hand on the baby and start to reposition the arm, that the movement has to stop. So usually you don't need to do anything if the jitteriness in the context of otherwise healthy newborn, and this is commonly to be seen in at least like 2/3 of healthy newborns. But in this case, given the history of gestational diabetes in the mom, you are worried about risk for hypoglycemia, which can be presented with jitteriness. And also you are worried about the risk here for effect of the SSRI. SSRI for depression don't usually typically cause seizures, but they can induce hyperirritability and can induce some movement disorders such as jitteriness, as you can see here. But the bottom line that this case is not seizures, but warrant some investigations, given the fact that the baby is quite jittery. This is another example of rhythmic movements that you can see mimicking seizures. I hope that you can see the video clearly here. You can see here that there is limb clonus here. In fact, this is not seizures. This is typically seen in cases while you have emerging hyperreflexia after hypoxic ischemic encephalopathy injury. The jerking movement here of the clonus is restricted to one joint, and commonly it's in the ankle joint. As you know, you can elicit the clonus, but this is like a spontaneous clonus. It's usually rapid, short in duration. Repositioning the limb by kind of blunter flexing the limb can reduce the stretch
Assalamu alaikum. It's my pleasure to share in this great conference. Thank you, Professor Sameh. It's my pleasure to introduce the next speaker, Dr. Jason Stoffman. Dr. Jason Stoffman is a pediatric hematologist and oncologist in Winnipeg, Canada. He's an associate professor in University of Manitoba, past chair of Hemophilia Twinning Committee, and currently the medical liaison for Canadian Hemophilia Society. It's our pleasure to have him with us talking about an approach to neonatal thrombocytopenia.
Excellent. Thank you very much for the introduction, and thank you for inviting me to come and join you in this conference. It's really quite a pleasure for me to be here. So I'm going to share my screen. And if we can see the screen.